introduce Dr. Willis in just a few minutes, but I know everybody came here because they wanted to know some about stroke. How many people in this room have been affected by a family member or themselves with stroke? Okay. All right. How many people know or were there at the time the stroke occurred? Okay. So, and did you know how many people in this room felt like they knew enough about stroke at the time they had it that they knew what to do? Okay, just a few. Okay, so let's talk about stroke. First of all, you know, there's so much to talk about in stroke, and we want to get to Dr. Willis very soon. But I will just tell you a few things that you can do at home to take care of yourselves if something happens. Everybody knows what the universal sign for heart attack is. Let's see it. Yes? Let me see it, you guys. Come on. Okay. This is a participatory group. Okay. All right. So the universal sign for you know, our cardiological colleagues have done a great job about figuring out how to get people to understand what to do about heart attacks. When you have chest pain, you call 911. So I would ask everybody to look at a colleague. Just turn around and look at somebody. I want you to look at their face and have them smile. Okay, I'm going to give you an eponym. F-A-S-T. F-A-S-T. And the people who are medical, you got to do this too. Back there, I'm watching you guys. Okay. Okay. If the face is asymmetrical, all of a sudden, then you know that something is wrong. It could be a stroke. Yes? Yes. Okay, so if you've got that, you need to think about, is this a stroke? Put your arms out like this. Okay, now and look at your nearby neighbor. If one of them drifts down, or if you can't lift the other one, if there's not a shoulder problem, then what I'm saying to you is and it's an acute problem, it may be a stroke. If somebody has a problem with garbled speech or cannot say, they're trying to say a word to you and they can't say it, please think stroke. Okay? So F-A-S-T, face, arm, speech, and T is for time. Dr. Willis is going to talk about his beloved wife, Tracy, and what she did to help him on the time that something happened to him. They've been very gracious to share this on Community 7 and here at the Billings Clinic, so I want to thank you both while you're here. Time means that you have a certain amount of time to try to get this person to the emergency room so that we can take care of the stroke. What are the risk factors for stroke? High blood, that we can do something about. High blood pressure. If you haven't had your blood pressure checked, please do so, and do that often. Cigarette smoking. In 2014, nobody should be smoking because it's terrible for lots of different reasons. Sorry to the people who sell cigarettes, but that's what... high cholesterol is more of a risk factor in heart disease, but it is also in stroke, so we try to treat high cholesterol. Age is something we can't do anything about, but we can certainly do something about moderate to heavy alcohol drinking. All of those things are risk factors. And genetics and family history. So those are some of the ground rules that I always like for people to know. What can you do very quickly and what can you do in the long run for yourself? So we have Dr. Willis offered on his generously to come and talk to this group today. I'm going to ask Mike a few questions and we'll go with it from there. Any questions before we start? Okay. I'm sorry?
Is there another doctor coming from a stroke victim, or is he the only one?
So Dr. Willis is the stroke victim.
Yes, but is there another one? The paper said there were two.
Oh, I'm sorry.
That's
sorry.
why I asked.
The answer is there's just the two of us. I'm the other doc.
Not the stroke.
No.
What you see is
What you got.
what you got.
Yes, Becky.
Do you consider
amnesia a stroke?
I always treat it at it. Okay. The question was, do we consider total global amnesia, TGA, a stroke? What I will say to you is that we treat it as if it is, work it up the same way, and if we don't find anything abnormal, then we attribute it as a last, because we've ruled out everything else, as a vasospasm of the vessels. The question's a good one. Thank you.
Thank you.
Yes. Yes, sir.
Alcohol, and you're saying no cigarettes, is it better off to have no alcohol?
Okay, the question is it better, are you better off to have no alcohol? In Montana, I hesitate to ask that question. I was going to go right on past that. But you didn't let me by with that. So there are studies out that a glass of wine, not a glass of wine, okay? A glass of wine has a small decreased risk of stroke. Small. It's not enough for you to go out and do something about that. But it goes right up with moderate and heavy drinking. So moderate is more than a glass of wine. Yeah? Thank you. Yes, sir.
How about a retinal infarct? Consider that a stroke?
The question is, what about a retinal infarct? And what that means is that there was an infarct in the retinal artery. You always have to consider that this might be causative from something in the neck. And that's a place that...
Carotid.
Yes, carotid artery. Yes. Good questions. So, Mike, you ready to talk?
You bet.
Okay, so what I would like to do is ask you to talk about the night.
You bet. So I have to always start when I'm sitting in a forum like this with the same question that one of my med school professors always asked to start his lectures. Am I audible in the rear? He will forever be endeared to me. So.
Or reared to you.
That's right. So the night I had my stroke on June 1st, 2013, and interestingly, prior to the stroke, I really didn't have any focal risk factors. I probably fell into the moderate alcohol consumption group, and not like talking about Montana. I'm from Louisiana, where moderate alcohol consumption is kind of pretty norm. So we have to really watch that. And I didn't have any family history of stroke, didn't have any personal high blood pressure. My cholesterol was normal, and interestingly, the year leading up to it, I had really recaptured my fitness in life, and I had lost about 30 to 35 pounds by lifestyle, food change, and exercise. And so I was in the best shape I'd been in for about 20 years. And the week before I had this stroke, I'd gone down to Salt Lake City to ride in a bicycle race that was 100 miles. And I had a bit of a chest cold while I was down there. So I was a little worn out from the ride and this cold. But I came home feeling great, and I actually rode the race in a kind of a record time for me for 100 miles. But when I got home the night before the stroke, I was going to bed, and I just kind of felt a little tired. I had a full operating day. In fact, if you could line up all of my favorite surgical cases, that's what I did on that Friday. And so it was just a phenomenal day, really busy, but just like I like them, and really a fun day, and everything just went beautifully. And went home that night and started resting downstairs, watching a little bit of TV. And we were leaving the next morning as a family. We have 3 little kids to go down to Florida. And I could hear at about 4:30 or so when I woke up, I heard my wife kind of finalizing, getting things ready for us to leave. And I thought I'd go upstairs to see if I could be of any help whatsoever, which I usually am not. But I walked upstairs and noticed that it was right at 4:30. And when I got upstairs and walked through the kitchen, the kids got up. I was kind of rounding them up and grabbing a bag. And I just suddenly felt very weak, kind of globally. Nothing focally, but I just felt tired. And so I took a knee in the kitchen. And as I was kneeling down, I realized then I could not get up. and then I realized my entire left side was weak, and I could not get up. And so Tracy started asking me about what was going on, and I couldn't exactly explain it to her. I just said, I can't get up, I'm kind of floundering here. And then she noticed that my speech was a little off, and she said, well, I'm going to call 911, and I thought that was a little overkill, but when I realized I just couldn't move at all, I thought, well, okay. And so she called 911, and it was very difficult to hear her talking to the dispatcher and to say, he's not really talking normally. I think he might be having a stroke, and that was just an awful thing to hear. But as Dr. Gaddy alluded to, it takes a phenomenal amount of courage, I think, especially for people, in our age group where those things aren't, quote, supposed to happen, for her to have said, yes, this is what's going on, and it helps that she has a medical background, so she knew. But she was brave enough to say it. And right when she said that, I think he might be having a stroke, I realized that's exactly what's going on. And in that moment, realized that my life was not going to be the same ever again. But then we got fantastic emergency care. Years ago here at the Billings Clinic, as part of expanding all of our service lines and delivery to public, the best care that we feel we can offer regionally, not just to mention the state of Montana. The stroke activation team was put together, and this is a multi-faceted, multi-departmental group that responds to stroke that includes the neurology team, the emergency department team, the emergency responders in the way of ambulance, etc., and the radiologists. So there are lots of people involved. And when it first got put together years ago, I kind of didn't know what it was for. I certainly had no anticipation that it may have a role in my life, but it did demand some resources, and I wondered, are those resources well spent? And what I found out the morning I came in, because we got here very quickly through the ambulance, and I began to get the emergency treatment for stroke here, including the clot buster drug. And we were well within the time frame of that. And I think that highlights the T of Dr. Gaddy's fast. Is you have to recognize exactly what time the symptoms start so that you know whether or not some of those interventional drugs can be administered safely and effectively.
So I'll just interrupt for a second here. If someone wakes up with the symptoms, we cannot give tissue plasminogen activator. It's called TPA. And the reason is we don't know how long the person has been that way. It may have happened 4 hours ago, unless we know that they went to sleep just 5 minutes ago, and they were normal right before that. But that's exactly right. And we only have a 3-hour window for some of our patients who are 80 years old and older. We have now up to 4.5-hour window for the patients who are less than that. But we have to have a lot of criteria to rule out people. But the TPA is better given the closer to the onset of the event as possible. So go ahead.
So I got evaluated by a CT scan immediately through our emergency department, and it was pretty clear what was going on to everyone. Interestingly, it just so happened right about that time of the morning, one of my friends who's a vascular surgeon was on call and coming through the hospital and saw us there. And I got to speak to him directly and one of our radiologists who's also a close friend. So I had an exceptional array of collegial consultants right away. And I think the important thing is because of the stroke activation team, all of those specialties are represented at our hospital for anyone who comes in. And that team and its function literally saved my life. And one of my colleagues made the decision that as I was coming in, she thought it'd be best if I went down to Denver. And so I got on an airplane up at the airport and flew down to Denver, which was the longest 2-hour flight on a prop plane ever. But
And so right now what we would like to do is tell the audience what happened to you. What was the pathology that happened?
Right, so I had what's called a carotid dissection, to go back to the carotid question. So if you think of an artery as a hose, and it is like a hose, it's got an outer lining that's a little bit thicker, and an inner lining that's a little bit thinner like a balloon. And sometimes arteries, be them in the chest or in the neck, can dissect where that inner wall literally gets peeled away from the outer wall. And that's what happened in my neck. And then underneath that inner wall, the blood under pressure pushes up and pushes it away more. And then blood can kind of come still there and form a clot. And then that clot went up to my brain. And it pretty much took out the blood supply to the right side of my brain, which is why the left side of my body was affected.
And what happens with stroke is that any part of the brain that is affected by the lack of blood flow or oxygenation is the part of the brain that will be injured, and that means that's why strokes look so different in different people. Sometimes it's an arm, sometimes it's a leg. Usually if it's the brain itself, it's the left side takes care of the right side. But sometimes it's deeper in its brainstem. I get this question all the time. Why don't I look like Aunt Susie when she had her stroke? Yeah.
They're all very different. And I got flown down to Swedish Hospital in Denver, which interestingly, as far as stroke activation teams go, was one of the leaders in the country in that, and is considered one of the top stroke hospitals. And when I rolled through the doors there, I can remember going into the emergency department at about 9:30 in the morning. So I was only 5 hours removed from the onset of my symptoms. So that was phenomenally fast treatment that I got here, and transportation all the way to Denver. And when I went in there to the emergency department, they were all amazed. They said, "Wow, you got this kind of care up in Billings." And I said, "Yes, that's what we do." And I mean that. That is, we are all very fortunate who live here that we have this healthcare atmosphere that is outstanding. It's on a par with any big city, but it's delivered with a small city feel and sense of compassion and community. And I feel really lucky to have been a part of that for a number of years, and I'm looking forward to getting back to it. But that team, I have to say thanks for putting it together, because I could have never guessed it would save my life, but it did.
So just to let you know, because our cardiologist friends had established the way, maybe 4 or 5 decades ago, people have done evidence-based data in comparing how to do things. I will tell you that in my time of practice, the attitude towards stroke has changed significantly. We have a stroke manager, Peggy Stribley, who helps us keep this stroke program on task, and there are people from all over the institution who have helped. And I'm telling you that that's true over the nation too, so that we can take better care of stroke. What I would say is that when people are invested in a situation, that is really very helpful, and the public has helped us a lot too, because educationally people have called up and when they are coming to a situation, a talk like this, then they get information, and I've had calls the very same day saying, "I think I'm having a stroke," and indeed they are.
Yeah, it's terrifying. But that's why information needs to be provided, and why we all need to be good consumers of healthcare and information. And I've always been impressed when I come to the Lunch and Learns. I can't tell you all how much I appreciate you being here, because we have an incredible variety of people show up with different backgrounds, and more importantly, very savvy consumers of healthcare who ask questions that are very real and very informative for me to try to answer, but as well for your colleagues in the audience. And so I got to spend about 3 months in Denver starting my rehab down there. I did end up having a surgery because my brain was swelling, so I had to have part of my skull taken out to remove pressure. And all of that care that I got initially in that regard is care that I could have gotten in our hospital, without a doubt. But I think that the docs who were seeing me that night made a call that was very good, which was, what I came into, I don't know the exact percentage, but my understanding is what I presented to the emergency department with has roughly a 14 to maybe 16% chance even of fatality.
I'll just tell you that worldwide, the mortality of stroke is number 2, and worldwide, the mortality from stroke is up to 23%. And that's all comers.
So I had something that I was quite possibly going to die from that morning. And my colleagues looked at me and said, it's going to be best if he gets out of here. Not because we can't take care of him, but because if he dies right here, just no one recovers from that. And I think that's a collegial answer. If it'd be as if you do tires for a living and one of your best friends came in and you mounted up new tires for him and then he drove off and blew up a tire and died, you'd never get over it. And so if I had been treated and did have one of those high percentage mortalities, then my colleagues would have not gotten over that. And so I'm glad they made that decision. I'm also glad that I wasn't a fatality from my stroke, of course.
Well, there was another reason we sent him. One of my colleagues was on call that evening, and she made an excellent call about sending him. And that was because there are interventional teams at Swedish, interventional meaning through the radiology and neurosurgery groups. And sometimes there are interventions that we can do intravascularly going through the vessels. And if there was any outside chance that we could have improved the situation, that was another reason why she sent you.
Right, and it was my understanding, even when I got on the little airplane up at the airport, that that's potentially what was going to happen in Denver. When we got there, the radiologist who was there, who's their interventionalist, who does that, where they thread a catheter up through the blood vessels to the brain, and then they administer the clot-busting drug directly in the clot. He said, we don't have a whole array of data on this, but what we do know are the people that we made worse and the people who died from our intervention are kind of middle-aged, kind of strong people whose bodies just suddenly reacted to this clot being broken up and showering through the brain. And I really respect that kind of judgment, because in medicine, there's this, like other professions, there's this saying that just because you have a hammer, everything isn't a nail. And sometimes it's hard to show that kind of judgment when someone walks in and has something that you think you could fix and you have the skills to fix. It's very easy to say, yep, let's go over to the operating room or our interventional room or what have you, and let's just fix it. But that physician also showed an incredible sense of judgment to say, well, yeah, we could try to fix it, but we also might kill you, and you came here specifically to not die. So I thought that showed great judgment, and we don't all do that in our lives. When we have a hammer, things look like a nail.
There was another important caveat of what Dr. Willis talked about when he said that he had swelling of the brain. That's very common in younger people. We'd like to make all of you aware that strokes can happen at any age, including in utero. In utero. So what happened with Dr. Willis, first of all, I once again, I'm so humbled that Dr. Willis has given me opportunity to share with you his case so that it can help you in the intricacies of his case. But the reason his brain required a craniotomy was that because there was no atrophy because of his age, and there's no room, this hard skull, there's no space for swelling. And in order to save his life, that's what they had to do at Swedish. Yeah.
They did, by the way, put it back in. So it was right at about a third of my skull was taken out, and they put it in the freezer. They assured me it was at minus 70 degrees. Which is interesting, because when I was in my residency training and we would have a neurosurgical rotation, they put them in the belly. So we'd put them in the belly fat, and that kept them hydrated with blood and nourished. But the reason they didn't do that is because as soon as people have a stroke, one of the first things you want them to learn to do is to sit up, because that's very difficult. And if you've got this piece of skull sitting right here, that makes it really hard. So mine stayed in the freezer. So I'd like to say I'm cooler-headed now than I was. I also asked the neurosurgeon right before he put it back in if he was the one running the drill to put the little screws in. And he said, why? And I said, well, if you have a resident working with you, I'd really like to talk to that person and tell them how much I'd appreciate the drill not diving through.
The good news, he got to leave Swedish and come back home.
That's right. After
Yeah.
3 months, I got to
Yeah.
get back home. And it's a long time being away from kids and being away from here. This is just about 16 months now. And so what I've realized is that because my left side suffered the paralysis, that the likelihood of me getting to operate again is exceptionally low because my left hand would have to make a near full recovery, and that's pretty unlikely at this point. But I'm lucky I work in an organization and with a group of people in my department who would have me back in any capacity that I can work. And I can certainly run a non-operative orthopedic practice, so I can still form relationships with patients. And then luckily I have this great array of partners to whom I can consult patients if and when they need surgery. And so that's my ultimate goal, is to get back to working in the office. And that'll take a little bit of time because I have yet to be cleared for driving, and I have to kind of work on my fatigue levels to get there. But I would tell everyone that the main thing I learned from this is, even with something dreadful like that, that your life doesn't end right there. You know, you just have to take that barrier, cross it, and keep moving on. Right. And that's been said by a lot of people in the world before, and they've all been right, but it doesn't really hit home, or didn't hit home for me until I had something bad happen. And I would share with anyone, this is the only real adversity I've been through in my life. I'm kind of very lucky that I've had a somewhat charmed life with very low levels of adversity, other than things that I've set as goals for myself. But I haven't had any major illnesses or things, or family deaths or anything of that nature, and all my kids are healthy. And so it's really strange to learn how to overcome adversity. I have learned a whole new language, that things I said to my patients before are probably not relevant. Like if I ever told anyone here who was having a knee problem, well, just straighten your knee when you walk. Feel free to come up and hit me in the knee. Because I've come to find out it's not just, it's never just. And it's not a matter of simply straightening your knee when you walk. There's a lot that goes into walking. And though I was 11 months when I started walking, I'm having to relearn all of that. And it's an interesting journey. At the end of the day, I hope that I'll always look back on it and say it was a fun one, and so far I have, because it's fun to set goals and then cross them. But it takes a lot of really good consultants to do that.
So I would like to close and give my incredible gratitude to Tracy and Dr.
My
Willis.
privilege.
I really appreciate, for two reasons. One is, Dr. Willis is exactly right. When a colleague takes care of a colleague, it's almost as bad for the person emotionally as if they were trying to take care of an own family member. And it's not wise for a person to be too close to their patient. Sometimes that happens. We're in a small town. But I will tell you that Tracy and Mike have blessed my life beyond what they can ever imagine. So I appreciate that.
And once again, as Dr. Gaddy already pointed out, you owe yourselves an acknowledgement, as well as being an incredibly well-educated and well-articulated audience, and we can't tell you how much we always appreciate these types of forums and you taking time to come over, because this is part of what we signed up to do. We believe very strongly that part of our mission is to be part of the community education for health. And I found myself, part of the emotional part was after I had this stroke, wondering, can I really continue to preach what I was preaching to everybody in terms of getting your fitness right like I was doing? You know, losing a lot of weight, changing my diet, doing a lot of exercise, or is that now debunked in my brain? And the answer I would tell you is that in no way has made me think that that was wrong. It made me healthier. it likely is the reason I survived this
Right.
stroke. I was physically very strong going into it, and if I had when I have the opportunity to get fit again, I will do it, and I'll do that through the same combination of my food lifestyle, which is, I believe, where we all can make better on our health, and my workouts, as well as just general taking care of myself, getting better sleep. That's what I would say, get better sleep. That's probably where I was off for so long.
Thank you so much for
Thank
coming.
you very much.
Very much appreciated.